Historically, suicide has been seen as a mental health issue. Therefore, suicide prevention efforts have largely been the responsibility of behavioral health practitioners. However, we now know that virtually all people who die by suicide have had contact with a healthcare provider in the year prior to their death, about 50% in the month prior to their death, and around 30% in the week prior to their death. Everyone plays a role in suicide prevention, even you.
I've incorporated suicide prevention into my family medicine practice in a variety of ways. It goes everywhere from how I talk to people who are well to how I talk to people when they are having mental health struggles.
I incorporate suicide prevention into my medical practice every day. I do it with all of my well child checks, and I use it whenever I'm following up on a mood disorder or if I just feel like someone's feeling sad.
So I've incorporated suicide prevention in my medical practice pretty much every day. Every day in the emergency department, we have patients come in who are in crisis for a variety of reasons. But when it deals with suicide, the major thing in the emergency department is just to keep the patient safe and have a patient-centered approach. That the patient is here, they're in crisis, we need to do everything we can to keep them safe.
We also know that primary care and medical specialty visits without mental health concerns or complaints were most common during visits in the month prior to death. Importantly, as many as 50% of suicide deaths occur in individuals without a prior history of attempt and no previously identified mental health diagnoses, but who may have other chronic health conditions. While it is not necessarily your job to treat the suicidality, it is important for all healthcare providers to know how to recognize, support, and provide care or a safe handoff to other resources for individuals who may be struggling. This brief training for healthcare providers will address 4 questions about suicide. First, why should you ask about suicide? Second, when should you ask about suicide? Third, how should you ask about suicide? And finally, what should you do if you determine that someone is at risk for suicide? Why should healthcare providers ask their patients about suicide ideation? Simply stated, because you could save a life. The single most effective intervention for suicide ideation is to ask.
The most challenging aspects about talking about suicide is the discomfort. Is it going to come across right? Is someone going to be comfortable to have this discussion? And just having time. Every time you talk about something that's risky, you can open up a can of worms where you need a lot of time that we don't always feel like we have.
The more frequently you have these conversations, the more comfortable I hope that you'll become. I certainly have become more comfortable having these conversations because then if I can bring my own comfort to the conversations, then they can see that I'm a safe person to talk to and that they can bring this up anytime that they want to.
Talking about thoughts of suicide can be very difficult for the person experiencing them. There may be feelings of shame, embarrassment, and fear. Most patients will not spontaneously share this information unless asked due to fear that they will just be hospitalized, misunderstood, or harshly judged. People are usually less inclined to act on suicidal thoughts once they have had an opportunity to share them and feel understood. Asking about suicide can be challenging for a variety of reasons. Your own fear or discomfort, concerns about urgency, limited time with patients, cultural narratives or stigma about suicide, and concerns about liability.
I would say the most challenging part about speaking about suicide has been that it can sometimes take time. So I find the time with people while we're talking about this to be actually really meaningful and a positive thing for me in my work. I feel like I'm making a really positive difference for someone. And generally they really appreciate it, but then it's my subsequent patients and I have to find a way to gracefully apologize for running late.
Sometimes it is very challenging to talk to patients about suicide. I don't have a problem asking the patients directly about suicide or thoughts of killing themselves. I think it really becomes challenging when there's a difference of opinion between a patient and their spouse or a patient and their loved one, where the stories are not the same. That takes a lot of time to get collateral information and think about really what is going to keep the patient safe. Sometimes patients will downplay their actual intent. Sometimes they'll have text messages or other things from family that really showcase a higher level of concern. Alternatively, sometimes the family members will have a different approach or a different thought about where the patient is at than the patient. And the patient may really be in crisis, but a family member is downplaying. So I find those are challenging interactions. And I think the best advice that I've been given is to really focus on the patient and their safety.
Your relationships with your patients are powerful. You may be the one person they can talk to and not feel judged. You are often the person they are coming to for help with other concerns. If you create a safe space where someone can share that they are struggling with suicidal thoughts, you have the ability to give them the connection that may save their life. When should healthcare providers ask their patients about suicide ideation? There are a large number of risk factors and warning signs that indicate someone may be experiencing a suicidal crisis. However, suicide ideation can come and go and is best addressed when the individual is not in crisis. Incorporating questions into regular discussions normalizes this as a topic of conversation between a patient and their provider. Many medical practices screen for suicide risk routinely, utilizing a brief screener such as the Columbia Suicide Severity Rating Scale, or CSSRS. Utilizing a screener such as this one can take less than 30 seconds. It can provide extremely useful information and can aid in normalizing the discussion of suicide risk within a healthcare setting. It does not have to take a lot of time. And most of the time, the answer will be no. But by asking, you are communicating to them that if or when such thoughts arise, you are interested, understanding, and safe. How should you ask a patient about suicide ideation? Ask directly. Dancing around a question or topic conveys discomfort and makes it less likely that someone will open up. Try, are you thinking about suicide? Or are you having thoughts of wanting to die? A question like, are you thinking about hurting yourself, is not the same as asking, are you thinking about killing yourself? Most people who struggle with suicidal thoughts don't want to hurt anymore, so hurting themselves is not what they have in mind. Asking, are you currently safe, can be ambiguous in that the concept of safety is vague and takes on different meaning for different people. After you ask if someone indicates that they are thinking about suicide, assess where they may be with those thoughts. Ask follow-up questions such as, have you attempted suicide before? Or have you thought about how you would make a suicide attempt? Have you made plans for when and where you would do this?
I think the rewarding aspects that come with conversations about suicidal thoughts is the opportunity to engage with the patient about ways to help them grow, help them find a way to stay safe, help them look for solutions. And sometimes I find surprises. I find times when I didn't know somebody was suicidal, and the only reason I found out was because I asked a screening question.
I think one of the most rewarding aspects about talking with patients who are having suicidal thoughts is getting them to a place of safety and having a real ability to help them. I have my own personal history with mental health situations, and so I can remember feeling cared for when someone actually asked me about what I needed. And so I think the question of asking people if they are in a place where they're suicidal or they're thinking about killing themselves, and letting them have the space to open up and really share some very important, very critical, very intimate details about things that they may be struggling with.
There are 3 words to keep in mind when asking someone about suicide: compassion, respect, and patience. Have compassion for what they may be going through, or for how difficult it may be for them to make themselves vulnerable. Respect their beliefs, their experiences, and their pain. This is not the time to judge, but to be present and listen. Be patient with their process of opening up or sharing. What should you do if they indicate they are at risk for suicide? It is not your job to fix someone's suicidal thoughts or feelings. Suicide attempt survivors often say what they really needed was to be heard. Sometimes listening and being present is enough. When they need more, know the resources you can provide to help them manage their risk. People often do not know where to turn when they are experiencing a mental health crisis. Be sure they know that during times of distress, they can call 988 to talk or text with a trained professional.
So I always give my patients 988. It's a very simple number to remember, and I also give that to the family members. So it's really easy, and even if they forget what was that number, it's like 911, 988.
In subsequent training videos, 2 evidence-based interventions, safety planning, and counseling on access to lethal means are presented. Both approaches are about empowering patients to better understand, prevent, and manage their own suicidal thoughts. If you feel that someone is an imminent risk, they may need to be assessed for a higher level of care. You can always contact 988 yourself and triage your concerns with a crisis worker. The crisis worker may either coordinate a visit from MCOT, which is a mobile crisis outreach team consisting of a licensed mental health professional and a peer support specialist, or provide you with alternative options.
Resources are actually more plentiful than I think we believe. It's easy to think there's no one wanting to help us, but that's not true. In my clinic, I'm really lucky because I have social workers who I can call at any time. If they're busy, I can also utilize an iPad resource. We can call MCOT, and MCOT will either come to my clinic or meet the patient at their home. I can also send them to the ER if I really feel like I need a lot of help. Besides that, I know that we can get them into some type of therapy. There's online therapies, there's video visits, there's so much available. There's also group therapies that are available throughout the city and the state, so we just have to look for them. Luckily, I think calling MCOT and calling my social workers gets them connected.
Before we finish today, I just wanted to talk with you a little bit about some of the questionnaires that you filled out when you came in. Do you remember all those questions that you answered right as you were coming into the appointment? Yeah. Thank you for doing that. One of the questions asked a little bit about whether you were having any thoughts of wanting to hurt yourself or take your life, and you said that you were having some of those thoughts as much as several times per week. Can you tell me just a little bit more about that?
Yeah, I guess I've just been really feeling very stressed and overwhelmed. And just I feel like I keep dropping the ball on one thing and then it kind of feels like it spirals. And I just kind of feel like it would be nicer if it was just stopped.
Well, thank you for sharing that with me, and I'm so sorry that it's been so stressful for you lately. What I'd like to do is just ask a few more questions about some of those thoughts and symptoms that you've been having. Is that okay with you?
Yeah.
Okay. What I'd like to ask first is, have you ever wished that you were dead or wished that you could go to sleep and not wake up?
Yes.
Okay. And have you ever actually had any thoughts of killing yourself?
Not actions.
Okay. I'll ask just a few more questions about that, if that's okay. And so, have you had any specific thoughts about how you might kill yourself?
No.
Okay. Have you had any intention of acting on any of these thoughts in any way?
No.
Okay. Have you ever, at any time in your life, done anything or started to do anything to end your life?
No.
Okay. And thanks for answering those questions for me. That's really helpful for me to help understand kind of how severe those thoughts have been. And so what I'd like to do now then is talk a little bit about a safety plan.
Okay.
To effectively achieve and sustain reductions in suicide, we must implement a comprehensive public health approach to suicide prevention, one that mirrors the prevention approaches used for conditions such as heart disease and diabetes. The more we educate and prepare ourselves on suicide prevention, the greater our impact on deterring suicide and decreasing the stigma that surrounds suicide help-seeking behaviors.
I think about one patient that I had many years ago who came in. She was a postpartum patient and she was just really struggling. And I just sat down with her, I looked her in the eyes and I said, have you been having thoughts about killing yourself with a baby? And there was this very meaningful pause, and then she burst into tears and she said, I am. and I just can't get it to stop, and I can't tell anybody about it. And so after a conversation for a while, we were able together to make a plan. And years later, she found my email through the hospital and was able to get back in touch with me. And as an emergency room physician, this is very rare, but it was so meaningful because it reminded me of the work that we do every day, and to get a patient like her the needed help that she really desperately was in need of. And now, you know, she's thriving, and she mentioned her family in the email that she sent me. So it was just extremely rewarding.